Eli Barron's going to lead it off. Thank you guys for doing this.
Hi, good evening, everyone tuning in on the East Coast or on the West Coast, and on the East Coast, I guess it's good night. But anyway, today I'm going to be talking about transforaminal lumbar interbody fusions, evolution to current technique, indications, controversies, and lessons learned over 10 years. The slides are not advancing. Okay. The first thing I need to talk about basically is TLIF before we get into the topic of TLIF. TLIF was the interbody fusion of choice for years for a lot of the spinal community. It was initially described by Jaslow in '46, and Ralph Cloward, of course, was a father of TLIF. He described his first 100 cases at the Harvey Cushing Society in 1974. Interestingly, where I trained, and I want to give credit where it's due, at Temple in Philadelphia, there's a lot of mention of Paul Lynn, who was the first neurosurgeon to publish in the Core Journal as a neurosurgeon, also about PLIF and its soft PLIF at that time, which was uninstrumented. There was a fair amount of disfavor with this operation in the sense that there were a lot of known problems with the surgery, including bleeding, dural tears, neurologic problems, and of course, graft migration, collapse, and pseudarthrosis. Pedicle screw fixation, however, reduced some of those complications. So it's unfair, in my opinion, to blame PLIF itself for everything in the days before pedicle screws, because we weren't able to robustly fixate the segmental spine. And complications of approach are basically one that many surgeons fear, especially this basically picture of spaghetti if that dural tear happens and you're trying to get into the disc space. As a result, TLIF was developed, and TLIF really was developed second as almost a evolution of PLIF to a more safe procedure. This review article basically was a systematic literature review and meta-analysis looking at 192 studies comparing TLIF and PLIF. And all of these, they basically they compare the number of patients with TLIF and PLIF, and they look at the complications. And universally, it seems that PLIF has a higher complication rate. And when they actually did their meta-analysis and came out with odds favored the TLIF substantially over PLIF, especially for neurologic complications. And before we go on to talking about this operation, we need to ask ourselves why fuse the anterior spine. In my practice, I've reverted in many of the 80-year-olds with mobile spondylolisthesis if I'm doing a decompression to putting in screws without an interbody. So why not go back to the days of the Herkowitz operation for everyone? Well, the reality is a posterolateral fusion may not work at every time because the anterior column may be insufficient. Basically, by putting a device in the anterior spine and putting an interbody, you reduce the motion. And additionally, this famous paper by Weatherly reported 5 patients with solid posterior fusions who had continued back pain. So in patients who have some sort of discogenic syndrome, a posterolateral fusion may not be enough. Additionally, biomechanically, 80% of the weight bearing of the lumbar spine involves the anterior column, 20% involves the posterior column. So load sharing is done better by having a reconstruction anteriorly. Posterior column tension band may not work without an intact or reconstructed anterior column. And I refer specifically to the Moskowitz paper, which if you look up in PubMed, Moskowitz et al. Is the first paper which comes up with TLIF. And even though this was developed by Jürgen Harms, it wasn't in the indexed American literature. Again, without anterior column support, physiologic loads will exceed the bending strengths of any pedicle-based system. So especially when you start going to multi-levels and reconstructions, you want to start thinking about things into intervertebral space. So TLIF, as I hinted, was popularized by Professor Harms, basically with the intent of achieving the same goals of PLIF with reduction of risk. The theoretical benefits include a unilateral approach to the disc space and spine, a lower risk of neurologic injury. Then the question comes of what about lordosis? And we'll talk more about that. It can restore the height of the foramen, and possibly there may be an indirect relief of central stenosis. We published this chapter, this was in the second edition of the Vaccaro and my book on operative techniques. And basically, it shows the anatomy very well in terms of the TLIF corridor. When I heard one spine fellow said to me, do you need to resect the pars in order to do a TLIF? Or do you need to create a pars fracture? And at that point, I knew that they didn't really understand what a TLIF was, because the TLIF corridor, by definition, has a inferior facetectomy and access by removal of the bone and essentially cutting through the pars interarticularis and letting you get to the disc space, which is marked over here as A. Note the exiting root here, which is noted as B. And the TLIF can be done with leaving bone over the exiting root. I don't actually like to see the exiting root if I don't have to, simply because the more I see, the more I can endanger. And things are better protected sometimes by bone and ligament and things that naturally live there. But the point is, the access to this disc corridor is very good because nothing lives above the inferior pedicle here. If this top pedicle is L4 and this one is L5, you literally have a nice window right above that pedicle to access the disc space and stick something in the inner body space. And basically, we work through the foramen to remove the disc. There are customized instruments and paddles and shavers, and then we're able to put an intervertebral spacer. And this is an example of one of mine you'll see later, where I basically put two C-shaped peak spacers way in the front to help, again, the procedure involved reducing the spondylolisthesis, in this case, simply by removing the stenosis and working the disc space. Now, this slide actually is from my book. I want to go back to that. Yeah, I can't, the video doesn't seem to be playing, but this is actually Dr. Neil Anand in my book, who basically is operating here and me assisting him as a fellow. But you can see in the middle here, you can see Dr. Anand working. In the middle is the dura. Basically, his sucker is protecting everything. Below is the pedicle, and the disc is accessed. And you look, the dura is not really being retracted. I don't see a root retractor. I don't see major tension, because you literally have a clean zone to access the disc space. And that's how the operation should be done, because once the disc space is cleaned and the end plates are rasped, you basically are releasing more material, releasing the disc, literally mobilizing the space, and then you get ready to eventually put in trials and an implant. Now, the question is, can we induce lordosis with TLIF? This is a very famous paper published by Brian Kwan and the orthopedic group at Jefferson at the Rothman Institute. And if you look at the slip angle, where negative is defined as lordosis and positive as kyphosis, you will see that they thought that this was not a lordosing operation. They didn't see significant differences in the slip angles in this isthmic spondy series of TLIF in the first, second post-op. But what they did note, however, was that basically the more anterior one would put the graft, the more the slip angle would be lordotic, and the more posterior one would put the graft, the more it would be kyphotic. And you can see, if you look at these slides here where people are attempting to distract off a screw, you stuff in a big graft and you leave it like that, you're going to get kyphosis. But if you work with a banana-shaped spacer and you're able to, especially if you don't distract on screws, and be able to literally use a cantilever technique and put it up anteriorly, you can get lordosis. And basically, they noted in their graph that, again, the more the more anterior the cage was, the higher degree of lordosis. And in that case, that's when Todd Albert eventually, I believe, developed the Bengal cage as a result to exploit optimal placement along the cortical apophyseal ring. Subsequently, in 2006, when I actually started at Cedars, Dr. Anand published his cantilever TLIF article. And I honestly think this is a monumental article in the evolution of TLIF, because he reproducibly, in a prospective series of 100 or so patients, showed he was able to get lordosis. And again, what they did in this series, and you see he doesn't have the screws in here, he basically prepares the end plates, starts after he's trialing, he's able to put a C-shaped graft all the way in the front, and eventually, with a little bit of compression, was able to achieve significant lordosis. And their average lordosis per segment measure increased from 2 degrees before surgery to 9 degrees after surgery. Subsequently, Chris Jaffrey and Radasukian and all the guys down in UVA at the time published another paper in neurosurgery showing a significant increase in lordosis at the levels of TLIF 20 to basically plus or minus 4 degrees. But in their paper, they basically did bilateral facetectomies. So what I'm starting to jump at and say is basically people do TLIFs differently, and things that they do may increase lordosis. In this case, bilateral facetectomies appear to be doing that. And one of the things that's very interesting in this paper that I'm going to go back to, if you see for a single level TLIF, they note a medium BMP is used. That's 8.4 milligrams of BMP. And for a 2-level, a large BMP was used, 12 milligrams of BMP. And that's important to put in the back of your head because we're going to talk pretty soon about TLIFs and BMP dosing. But if you look at the change of lordosis at the fuse segment, this is a substantial amount of lordosis. This is a really, really lordosing operation in the way they corrected it. And if you go, the higher you go in the spine, the less lordosis you can achieve. For example, L1-2 with a bilateral Ponte osteotomy-like technique, they are at 6.4, but at L4-5, they're down at 12.9. And when they do a couple levels together, they really can get about 30 degrees or so of lordosis. I saw this paper recently from Minnesota from Dr. Polly's group, where they did a TLIF, where they did a bilateral facetectomy, and then they have this table that basically is a hinge table. They extend the table -5 degrees, then -10 degrees, then they put the rod, and they literally are using a combination of facetectomy, disc release, and table extension to get 42 degrees of lordosis over here. Pretty fascinating, but it just goes to show you, all of us do ACDFs in the cervical spine, and we all know about dropping the head in terms of removing the donuts to get more lordosis. This is effectively the same kind of thing with a table that's able to give you more than an average Jackson table. And basically, they conclude 27 degrees of segmental lordosis correction, and they basically show they advocated in this case of facetectomies and their tables. An interesting follow-up paper was by Mike Steinmetz's group and the Cleveland Clinic in spine, where they compared single to bilateral facetectomies, and in their case, they didn't really find a difference. In both of them, they were able to get significant lordosis, where with a unilateral facetectomy, they got 22 degrees on average, and bilateral 23, but there was no clinically significant difference. Interestingly, in terms of QALYs, they found that the pain disability quotient and the QALY gains were better with people who had the bilateral facetectomies, possibly because they got a bilateral decompression, and possibly because radicular pain was less likely an issue because both sides were decompressed. But my only point in saying that to you is that they did not see this massive increase in lordosis by doing a bilateral facetectomy. Moving on to cage types. We are now in the era of expandable cages. Everyone has them. Cedars finally has them, but everyone has them at their institutions. And cage type may influence our type of lordosis. In this review, basically, a single institution looked at straight cages, banana cages, and expandable TLIFs. And in their case, the only one that they found having sustained gain in lordosis were the expandable cages. And they basically theorized this was related to end plate damage. And also, if you looked at Dr. Anand's paper, he was so good at putting those grafts anteriorly. Many surgeons, it can be hard. And literally, if you don't make that cantilever TLIF work perfectly, it may be hard to get lordosis as reproducibly as an expandable cage. But the expandable cage literature is literally all over the place, with some papers saying that it creates better lordosis and other papers suggesting that it doesn't make a difference compared to other ones. Now, moving on, and I see the TBI people, especially Dr. Ziegler in the audience over here, where ALIF is king above everything else. This review published in 2012 by Zhang et al. Basically asked which was a better operation, ALIF or a TLIF. And basically, they looked at papers comparing these things head to head, and they were able to get a lot of different groups or paper series, basically looking at complications, but also in fusion rates and segmental lordosis. And basically, if you look at the complications, it's very, very typical. The ALIF as a whole, you see things like deep venous thrombosis, where the TLIF, you probably see a higher rate of radiculopathy and neurologic things. With the ALIF, this one series from Dr. Villavicencio, who is a Cedars alum, in their institution, ALIF, there was a blood vessel injury, DVT, PE, in PLIF, they write PLIF, but it's actually TLIF. CSF leak was a higher rate, neurologic deficit and infection. So it's basically what lumps and bumps do you want to take? No matter what you do, you're going to come across. And people say to me, "Oh, Eli, you're a TLIF guy," and I just look at them funny because that's like saying you're a hammer guy versus a screwdriver. They're different operations. They're both useful. I don't think you can be one guy or another. Shea et al. Simply, again, similar things: retrograde ejaculation, delayed hematoma, the TLIF, wound infection, durotomy, vertebral body edema. But the point is, the complication profile was different. In terms of blood loss, on average, ALIF lost way more blood. On average, ALIF had more operative time, especially if you were doing a front back. And in terms of radiographic outcomes, ALIF in general was better in restoring lordosis, but not always and not all series. And in terms of clinical outcomes, they had no difference. Additionally, fusion rates were nearly identical. I love when people say, "Oh, I'm going to have a great ALIF. I will never have a pseudoarthrosis." I did a 2-level ALIF on a guy who smoked 2 packs a day. I used a lot of BMP. He convinced me to do surgeries. I had great pedicle screws. Now I have a 2-level pseudoarthrosis. The point is, ALIF can lead to pseudoarthrosis too, as can TLIF, although obviously with ALIF, it's easier to get a good discectomy, and it's easier because it's right in front of you. They conclude that both are useful operations and there's no significance between the complication rates, and the lordosis, the geometry was better with ALIF, but costs of ALIF were greater and clinical outcomes were very, very similar. And we are about clinical outcomes, guys. We are not only about radiographic outcomes. BMP and TLIF, I need to talk about this because this topic is one that really, really irks me because and to quote Dr. Anand, you wouldn't take a medium Tylenol or a large Tylenol. You know what milligrams you're dealing with. Unfortunately, in the TLIF world, people do things all over the place. By far, the best study I've seen on this is the Kahn, not the Kahn review. The Kahn review, it's not at, it's the little paper, but the Kahn paper talked about people getting BMP for TLIFs versus iliac crest. And in their follow-up, they basically determined that there was no significant difference in fusion rates between BMP and iliac crest for TLIFs. But with the BMP group, there was a higher rate of radiculitis and seromas. And the little paper, which is the meta-analysis just published in the Spine Journal, is, I think, marvelous because it takes every large series of TLIF and studies what happens with the BMP in different categories. And we're going to review some of that. Basically, they looked at 22 articles after a systematic review and did a meta-analysis. They basically went through their methodologies. They excluded things that weren't reported, weren't blinded, and they came up with a whole bunch of charts. And Dr. Anand, if you're still listening, your paper's on here. They basically list a whole bunch of studies in terms of whether they were randomized and not. They qualified how good the evidence is, and then they come and they basically do an analysis, which is a meta-analysis of the BMP, its location, and its complication rates. And it's amazing because I put this chart out here. Look at the range of BMP use. 8 milligrams per level, 1.28, 11.1. It is all over the place. There is no standard BMP dose in the literature. And basically, when they look at complications, the radiculitis rate varies from near non-existence to 57.1%. The HO rate varies from 0.6% all the way to 40%. So what's really going on here? Well, look at some of their forest plots and you'll get some answers. And they also looked at fusion rates of BMP for iliac crest bone graft. And in their forest plots, they note that BMP is actually favored for a higher fusion rate than iliac crest. The next thing is they do fusion by dose group. This is very cool because up top is large In the medium BMP, small BMP, extra small and extra small. And if you look at all these groups, there isn't much of a difference. So whether you're using a 12 milligram in a disc space or 1 milligram, which I actually happen to at this point, the fusion rates based on that meta-analysis are no difference. In other words, you're not getting a better result by giving more BMP. And again, it may be, again, your headache isn't going to get better if you take 5,000 milligrams of Tylenol. I assure you, it may get a lot worse though. But anyway, in terms of radiculitis, where do you put the BMP? I've worked with surgeons who put it in the cage. I've worked with surgeons who put it in the posterolateral gutters. I've seen surgeons put it in the inner space. What about the inner spaces and posterolateral gutters? They basically look at patients. If you put it in the inner space alone, you seem to have the highest likelihood or highest odds of radiculitis, as opposed to if you put it in the inner space and posterolateral gutters, it may be slightly lower. Overall, it exists though wherever you put it, and it's not clear where the BMP based on a meta-analysis is better to put. In terms of HO, there does not seem to be a dose-dependent result in HO. In the Kahn and Crandall series, they have very large doses of BMP, but they don't have HO as high as some of the other series looking at much smaller or extra small BMP. But before we conclude that BMP simply will cause HO in a dose-independent manner, I assure you they all do TLIFs differently. Crandall's paper, I love it, because what Dennis Crandall does is actually, again, similar to Dr. Anand, he packs soft bone graft behind the cage, behind the BMP, and that may actually, in theory, reduce some of the seroma formation. In other words, having active substrate for that bone morphogenetic protein to work on may make a difference. So my point is the problem with us looking at this from 30,000 feet is we don't know that all these large and medium and small TLIFs are being done a same way. But all we're looking at right now is a dosage of BMP. Again, in terms of heterotopic ossification by location, the most was seen when it was put in the inner space and cage, with a cage alone being slightly less and the inner space and posterolateral gutters being slightly less. In terms of osteoporosis, putting BMP inside of the cage seems to be a slightly higher risk factor than putting it simply in the interspace. In terms of a meta-regression rate for fusion, there was no difference in their analysis in terms of where you put the BMP to get a solid fusion, but there was a slightly higher chance of that happening if you put it both in the posterolateral gutters and inner space, but it did not achieve statistical significance. So no one from this paper was able to tell you for sure where to put the BMP and where not to. Just one thing about cages, they're great if they're used right. They can help restore lordosis, but there is this series basically from China looking at a TLIF done with morselized allograft rather than cage, and in their series they found no difference in fusion rates. This is not a radiologic paper in terms of lordosis, but the point is you can do that soft TLIF if you need to, especially in an older person, and get those two bones to join together, potentially with just using crushed lamina or posterolateral elements and putting them into the inner space. What about osteoporosis? Actually, I have a lot of patients like this where you basically do a TLIF anyway in an older person with stenosis, with a spondylolisthesis, and say they haven't been on Forteo that long, and you go ahead. What does the literature say about them? They definitely have a higher rate of subsidence. This is a retrospective study of 70 patients. They basically, or 88 patients, they had a higher rate of subsidence and a higher rate of fracture and a higher radiographic complication rate, but almost none of the patients went back to the OR. And I've seen this. I have patients where I've had a cage back out a little bit or screws loose. And I have one now who, unbeknownst to me, was a smoker, even though before surgery she said she wasn't. And she had some pain. And I haven't revised her, but things seem to be in a great, the screws, because they backed out a little bit, have not backed out completely. And I wouldn't be surprised if she goes on to not needing another operation. In terms of my own experience from 2007 to 2020, and I call these these are only patients who were my patients who saw me before and after. I've done to date a total of 304 patients with a total of 363 levels, the average age being 53.75. My overall neurologic complication rate, I'm embarrassed to say it's not zero, but I've had 6 patients with some deficit post-op, which is 1.97%. Infections, 1.64%. Pseudoarthrosis, I am putting this number out there. It may be slightly higher, but in terms of the ones which almost all had CTs, it was about 4.28%. Hardware malposition requiring revisions, 1.32%. And HO needing surgery, I had 14 patients, which again seems like a lot, but in 304 patients, being absolutely honest, it's gonna happen, especially because I've changed my technique because I thought I was getting too much HO. If I look back at my neurologic complications, and this is because bringing this up because the topic here is a case conference and what I've learned, looking back at cases, most likely to occur when impacting a trial or a spacer. Either my trajectory was off, like one time I was using the O-arm and I thought I could completely rely on it, and basically everything was shifted and there was no neurologic complication, but it very well could have been one. Bad bone and retrieval can be dangerous. You can put a spacer in, you don't like it, you try to get it, that retraction or even going outside the spine, bad things can happen. So the take-home message though that I wanted to say is, especially for the orthopedic surgeons, revision decompressions are not the source of complications in my hands. You can literally, using the burr, using microsurgical techniques to remove bone and even scar, and even getting a durotomy does not make you that much more likely to have, in my experience, a complication that with a bad neurologic deficit. More likely, again, the disc wasn't released enough, something didn't go smoothly, but the impaction is, to me, is the most dangerous step of the procedure. And in that regard, I've moved to using a lot more expandable cages, but I'll comment about that in a second. In theory, they're safer. And back a bunch of years ago when Stax was on our shelves, I was doing a lot of them and every single one of mine fused. And I thought, I found the holy grail. This thing is amazing. So you avoid impacting a larger trial, no need to impact the spacer in position. Great, we've solved all our problems. More lordosis, less damage to the end plate. Then I published as a second author this article of spine that I did as a surgery at the time. It was one of Dr. Levesque's patients. We did this TLIF together with Peak, Spacer, Expandable. We were proud of ourselves. The person went on. He had not done one before. I made sure it was great. He was so happy. He's like, Eli, let's move on. I love this technique. He calls me a month later. The person has a foot drop. The expandable cage has effectively imploded. One of the wafers came out, impaled the L5 root, and I had to take it out. And of course, I called the company and we did, and they said they never heard of such a thing. And then lo and behold, other people published the same thing in the literature. So if they didn't just hear it, the point is, I had this new technology in my hands and I thought it was so good, but it obviously could cause something. And in this case, it caused a very real complication. And it may have not been when I hit it, but 4 weeks after surgery, to me, is just as bad. HO, minimal BMP dosing. I'm using less than, I'm trying to use about 1 milligram per level. I put a lot more BMP in the facets and posterolateral gutters. I really do everything I can to try to keep it away. But whether that strategy will work in the long time run, I seem to be getting less HO patients, but maybe they're following up with other people. I don't really know the answer. There may be a role to backfilling the disc space. Now, moving on to my case that I was going to present where I thought would be a good operation. This was a 71-year-old gentleman I actually did 2 TLIFs on. He came to me back in 2012. He had a microdisc done at a minimally invasive endoscopic facility. And of course, he got infected. And he had 3 washouts. He comes to me with 102 fever. And I performed a TLIF on him with evacuation of his abscess. And he did well. He liked me a lot. Comes back years later, and now he has weakness in his leg and he has a foot drop. And he has these are his x-rays. That's my TLIF. Yes, the screws are in good position. It's just scoliosis and it's tilted. And in this case, you can see this is how he stands. He has dextroscoliosis of the lumbar spine measuring 34 degrees. His SVA is about 8 centimeters. His pelvic tilt is about 27. His PI is 72. And he has 14 degrees of kyphosis across the L23 disc space. And I measure on our computer system his lumbar lordosis to actually be 19 degrees of kyphosis. Anyway, so looking at this guy, I basically see that L23 disc on his CT. You can see he has a real solid fusion mass. It's open and he has an autofusion above, and he has severe stenosis there, and he has stenosis above. And basically you see all that gas in the disc space, and I'm salivating because I'm thinking some sort of cantilever TLIF coupled with osteotomies can help out. But of course, he has severe stenosis at L5S1 in the foramina, and I know he's going to need to go to the pelvis with any restoration procedure. So anyway, I start with the workhorse to me for L5S1 that is big, in this case an ALIF, and basically put in a hyperlordotic cage. Then I do the back, the TLIF, and basically do chevron osteotomies in addition to a laminectomy, compress across, and also use the bending irons across. And then we're able to get down across that space that basically that now measures a correction of 28 degrees across that disc space, with his SVA now back at 4.5 centimeters and his pelvic tilt down to 22 degrees, which is better. And he did well for about 6 months until he fell in an airport and fractured his spine above. But my point was to show the corrective abilities of basically the combined facetectomies coupled with a cantilever TLIF at L23. Next person is going to be Dr. Trontis speaking his next case.
Do we get to discuss in between?
Yeah.
Oh, I was going to say to Eli, it was a great presentation, some really honest data, and you know the real disconnect that we have, and I think one of the other discussers on the chat room mentioned it, is at the end of the day, it's the patient outcomes is how they do. And yeah, I mean, you mentioned in one of the papers that with ALIFs, you can do better lordosis correction and this and that. But at the end of the day, there's not a ton of difference, at least for 1 or 2 level degenerative fusions on the particular type of construct you do. We think like you said, TBI guys, we're kind of an ALIF practice. We think we make pretty x-rays, but I would say your results are, equal to really across the board. So, thank you for that. And, the interesting thing that I found was, at least with the BMP, and I think you were really honest with the discussion, the TLIF or PLIF or whatever with BMP is really the only operation that you have revisions from HO. You don't really see it with the other surgeries. And, I know that you said that you've modified your dose and, perhaps you could comment on the fact that you're seeing it less now, or maybe using alternative bone grafts in the TLIF cages.
I'm seeing it less. I actually have a paper that it literally got rejected from operative neurosurgery, but I'm currently revising it with patient-recorded outcomes on using navigation, neuronavigation, and O-arm to help resect the TLIF-related HO. And some of the patients that I include in that paper are actually they're not mine, in the sense they've come to me from other doctors. So I don't buy it when I hear people, because I heard other people nationally speak before about TLIF, that they never see HO. They're not looking for it if they're using BMP, because it exists. Because obviously you've seen it before. Everyone I know on the East Coast has seen it before. And if you're honest with yourself and you look at CT scans, you'll see it. And it's often asymptomatic, but to think it's not there, it's there. And I've tried using less and less BMP as a result. And I don't now have a practice of pseudoarthroses all day. So again, unless they're failing at a later date or they're going elsewhere, I think we were thinking, oh, we need to put in enough glue to get this to grow or this or that. But it was based on our gut saying, oh, it has to be there. But this stuff is very powerful, and it may be too powerful for the way we use it.
No, it's great, honest results. Thank you.
And Eli, we've certainly learned that lesson because we use BMP in just about all of our ALIFs, but we use a real small amount. We use, one sponge or 1.5 sponges, and we do not see that osteoclastic reaction that you sometimes will see in cases that are referred in, where you get big cystic changes because it's a dose-related phenomenon, and just the bone breakdown that's stimulated by BMP exceeds the bone growth that's stimulated by BMP when the doses are too high. So I think the lesson for all of us, whether you're in the interbody space from the front, the back, or the side, is to use less BMP rather than more. But it's a very good adjunct for fusions that's stood the test of time.
I guess we'll move on to the next couple of cases with first Dr. Trontis.
You're muted, Dr. Trontis.
Andrew, we can't hear you.
I don't know if his audio is working.
All right, how about that?
Yes, we're good.
Wonderful. Sorry about that. So I have two relatively simple cases, elementary cases for the TLIF, both focusing on degenerative spondylolisthesis. In our first case here, we have a patient who's a 69-year-old male who presented with severe right lower extremity radicular pain, as well as some right lower back pain. Physical exam was notable for 4- out of 5 right quad weakness. On plain radiographs, we can appreciate here a degenerative spondylolisthesis at the L4-5 level, as well as a general loss of lumbar lordosis. MRI here demonstrates a free fragment disc herniation on the right side at L4-5, which you can see better in the upper than the lower photo. This patient underwent a single level posterior instrumented fusion and TLIF. Here you can see fluoro shots from the case, which show the shaver in place. Here's placement of the TLIF graft. And finally, final x-rays show appropriate position of the graft, anterior position, some restoration of lordosis, segmental lordosis at that one level, with a slight reduction of the spondylolisthesis. Second case is another degenerative spondylolisthesis case, this time at 2 levels. This is actually the case that Dr. Barron had shown previously in his slide. This is a 70-year-old retired nurse with a history of rheumatoid arthritis who had global weakness in her legs as well as back and leg pain. Here you can see her plain radiographs, which show mobile spondylolisthesis at 2 levels, 3, 4, and 4, 5. MRI is not available, but did show a free fragment at L3-4. We only have one intraoperative shot here, which shows good reduction of the spondylolisthesis at both levels, as well as TLIF graft placement. And here are our final x-rays, which show restoration of some lordosis across these levels, as well as reduction of the spondylolisthesis.
And Andrew, interestingly, she's seeing me now with spondy at the next level, and both of her hips have been replaced and both of her knees have been replaced. So this is not a cure at any level.
So she's got a boat named after her from one of the arthroplasty surgeons.
So it's interesting that the intraoperative film shows really nice lordosis, but that postoperative film shows loss of your intraoperative correction. And I'd like to hear the deformity guys comment. Number one, I mean, that's a beautiful intraop film, but post-op film doesn't really reflect that. But then again, in an elderly population, if symptomatically they've had a good result, is it really that important? In a 70-year-old, I don't know. I'd like to hear some of the Scully guys talk about it.
She had to go. She went on to get hip replacements in the next couple of years, so I don't know if that's a factor too.
That's a good point. And I think, as long as we're talking about it, I think that's one of the criticisms about some of the TLIF papers is they talk about the restoration of lordosis on basically immediate post-op films, but long-term, and I think Vince Arlett mentioned it as well in some of his comments, that, you know, a year or 2 years down the line, that they lose the correction with a TLIF graft compared to some of the other constructs.
So I think just to Scott, the loss of lordosis can be explained by different ways. We may often see a little bit of subsidence and the TLIF or around the TLIF. Then the fact that we're using polyaxial screw and sometimes small titanium rods doesn't help. It's a little bit of bent, and sometimes you have a little bit of play on the crown screw interface, and everything together. If you put everything together, the osteoporosis, the little subsidence, the flexible rods, the small rods, the little bit of play in the crown screw interface and the long constructs makes it that you lose some lordosis.
Scott, you bring up a great point. It's Neil. I think the other issue we don't see is TLIF is technically pretty demanding. And I think just having taught fellows for years, Eli has done a great job picking it up and running with it. But it's not an easy operation. Whatever we think about it, we just think it's easy. What I mean by technically, there's so many issues. For example, subsidence, right? There's invariably end plate violation. If you're really honest with yourself and you go back to that x-ray, you blew that end plate somewhere. So you don't see it on table, they get up and go and they subside and they collapse. So I find it hard to believe with the pedicle screw and a good interbody graft that you're going to get a lot of subsidence other than some resorption, which shouldn't go down. You've blown that end plate at some point. So I think there's so many other things like that that maybe also confuse the issue. But there's no question you're not going to get the same lordosis, the TLIF, that you will get with an ALIF. That's a no-brainer. It's just not simple no-brainer. So I tell you, if you want lordosis, do an ALIF or even a lateral. You're not getting lordosis unless you do an osteotomy. And if you want to maintain it, TLIF is fine. I think it's a simple way to look at it.
Yeah, I think we're asking too much of the TLIFs to make the support, to maintain all the correction compared to, as you said, you know, a lateral or an anterior or an oblique, where you get a much larger surface area. I mean, especially in the elderly, especially with, as Vince said, with polyaxial screws, you're just not going to have that same mechanical stiffness, so to speak, as you would have within a large interbody graft.
I'll admit, this is my absolute favorite operation even to this day, but I literally do only single levels now. I'd rather do a lateral and multi-levels or even an ALIF. And it's definitely a change. And you see that. You sort of, but it's still one of our favorite operations, a great procedure to learn.
Yeah, the TLIFs give a lot of access to the disc when you're doing it, but you don't get the support you get from the ALIF constructs. With an ALIF construct, you have a much bigger biomechanical surface area, and it ends up protecting against subsidence much better, especially with the newer devices. I remember when the LT cages came out and all the BAK cages, there wasn't as much surface area, but now with most of the devices, we're getting a bigger footprint, which is preventing subsidence. And I did probably half my cases as TLIFs for many years, and I've gone almost entirely away from it because the ALIF just works better in terms of sagittal coronal balance, preventing subsidence and restoring the overall angle that we need at each level. And so it just, to do the TLIFs routinely, I think that they are in exceptional cases if you need to be decompressing, but it doesn't make sense to me as a go-to operation the majority of the time, because I think there's better technology today.
And if you think about it, if you do an ALIF or an OLIF or a lateral interbody, the pedicle screws are just as a secondary holding device. Whereas when you do a TLIF, the pedicle screws really are your main support. I mean, you're trying to support those vertebral bodies from subsiding on the small TLIF graft.
Dave Polly just made a comment, which I think is worth talking about, is ALIF is very dependent on your access surgeon. And what we're seeing now is a bunch of young general surgeons coming out that are embracing spinal access. And there's, societies and such like that, that at least in most major markets now, you should be able to get an access surgeon that's really, really well trained, that can go to these meetings of the access surgeons and kind of see what's best practice. So yeah, I just want to comment on Dave's comment, which was a really good one.
I wanted to bring up a point, Eli. When I do TLIFs, I notice that the entrance, it's usually a fish mouth kind of entrance, and you end up putting a smaller graft as you tamp it into the actual disc space. Once you get to your final position, it's much wider anteriorly than posteriorly. So I wonder if that has anything to do with the amount of loss of lordosis and what the role of these expandable cages are now that you're able to insert them small and kind of expand them size to fit. If you've noticed, or if there's been any literature looking
Right,
at that.
and I did mention that there are series showing them retrospectively to have better lordosis even than banana cages. But there are on the market banana cages that are expandable in that regard, that go way in the front, that are expandable, and you literally can put something in 7 millimeters, line it up anteriorly, and then have something, a jack almost in the front of the spine. So the TLIF that Dr. Schiller was talking about, for example, may not be the same TLIF in 10 years.
But Eli, it's still dependent on doing good surgery. You still have to get a good clean out, not violate the end plates.
Oh, absolutely. But
get some ligamentous release. Yeah, because depending on that as a carjack, that's a good way to fracture into.
Oh, of course. But I do a fair amount of ALIFs. I also do a fair amount of laterals. I feel like you have to do good surgery for those procedures.
Right.
Yeah.
I think that's the lesson for the young guys listening is it doesn't obviate the need for doing good surgery.
Your Dave's comment on the ALIF needing a vascular surgeon. I think, in fact, that's the very reason all the young guys need to learn how to do a TLIF. They're not going to get that vascular surgeon every single time. You got to have another way to approach that spine. And it's a good way to know that. You got to know this technique. There's no question. Should be in armamentarium. I mean, to Eli's point, there are guys out there will never do it. They'll only do an ALIF. I mean, or only do a TLIF. I don't think it works that way. You got to know them all. And then use it appropriately. That's unfair.
No, and I've done these. We've done these together, Dr. Anand, but also Terrence. TLIFs for infection. You think, oh, you need to clean out the disc space, do an ALIF for infection. I've seen so many HIV patients who come, for example, with ascites. No vascular surgeon wants to touch them. Who have discitis is unresponsive. TLIF with a bone graft, screws, again, using it for a different purpose. You avoid all the morbidity in a person whose abdomen is a nightmare.
Oh, it's a great procedure.
Anyway, we have 2 more cases from Dr. Hanna.
Thank you for allowing me to speak tonight. Can you guys hear me?
Yeah.
Yes.
Okay. I have some interesting case to present on behalf of Dr. Barron. So next case involves a 37-year-old ED physician from an East Coast hospital who was referred to an academic medical center in the Los Angeles area. However, as his parents, this ER physician was referred directly to Dr. Barron instead. He was complaining of progressively worsening back and leg pain, right greater than left, and it was interfering with his ED duties and his overall quality of life. On physical examination, he was neurologically intact, other than for the radicular pain. As you can see here, he has a isthmic grade 1 spondylolisthesis at L4-5. Here are some of his images. As you can see that pars interarticularis defect on the and partial fracture bilaterally, as well as in the coronal plane. On MRI at that segment at L4-5, you see bilateral severe lateral recess and neuroforaminal stenosis. It's worse on the right, which correlates with the symptoms. This is some intraoperative imaging. I don't know why that.
Yeah, it plays. It's a video if you go back.
One sec. Yeah. There's a video. You can see the approach. Screws are placed, pedicle screws. Disc space is distracted. The graft is measured, and then the final interbody graft is placed with restoration of height and a reduction in the spondylolisthesis. Patient did very well post-operatively. Our next case involves a 72-year-old female with a past medical history of back and leg pain that's also worse on the right side. 2 years prior to presentation, she underwent bilateral L3-4, L4-5 decompressions via unilateral approach, trying to do the minimally invasive thing. However, while this initially improved her symptoms, she eventually presented with worsening lower back and leg pain. As you can see here, she developed grade 1 spondy at L3-4. She also had pretty good coronal balance, but there was a slight levoscoliosis. As you can see, here's the MRI demonstrating that retrolisthesis and associated severe lateral recess stenosis. So Dr. Barron performed L3, 4, 4, 5 TLIFs with good restoration of height and correction of lordosis. However, you can see at the segment above, there's a little bit of retrolisthesis of 2-on-3. And she went on to do well. However, she quickly developed severely worsened back pain without relief with conservative measures. And as you can see here, that disc space collapsed significantly. There's severe neuroforaminal stenosis at that segment. And Dr. Barron went on to perform a 1-2 to pelvic fusion with I believe Dr. Barron, you did you also did a
I did laterals at 1, 2, and 2, 3. I did a strictly transpsoas approach up there, and then posteriorly instrumented or L1 to the pelvis. With that case, I was on the titanium craze. Everybody was saying titanium was so good. Try revising some of them. They can be a mess, but put a titanium TLIF cage in and a unilateral iliac screw as she wasn't really osteoporotic.
She's been doing well since this time.
So basically, in summary, I still think it's a great workhorse and a good way to restore the anterior column. Again, you need to know where to use it. If you need to put in a giant spacer and a disc height that's 18 millimeters, forget about it. Obviously, there are some very strong indications too to be well versed with lateral approaches and anterior approaches. Lordosis can be achieved, we said. We reviewed all the issues with BMP. We saying that expandable cages may be easier, may create more lordosis, and may be safer, but again, they're evolving. They're a technology that hasn't hit its final point. Thank you very much.
Thanks, Eli. I mean, this is exactly what we wanted this series to do, is to have somebody who's an expert reviewing the literature and giving his experience and then showing some cases. So you mission accomplished, did a great job and a good literature review. You know, obviously this is the #1 interbody fusion operation done in the US. So a lot of people agree with you that it's their go-to workhorse. Scott, did you have a comment you wanted to make there?
No, great session. I thought it was really provocative. Hey, Pat.
Hey, Scott, how you guys doing? Thank you all very much for having Eli. He is truly our expert here, and we defer to him for all of this. He and Neil have done a great deal to become the experts and promote really some scientific work, which is good, and it validates everything that you know, people are needing, because you know, there's a lot of data out there which is hard to believe, and you know, and I think that just adding some common sense to it's what's really, really important. And so thank you guys for putting it on, and thanks for inviting and having Eli. So
yes, Eli, thank you for a very, very great presentation, very honest and sobering. Thank you.
Thank you.
Thanks, guys.